In this section of Chapter 84, Inner Ear Disturbances, I chose tinnitus because it is also so problematic for our patients. It's a perception of a sound when there is no sound in the environment. It's usually chronic, benign, annoying, ringing, buzzing, hissing, high-pitched screeching, whistling in one or both ears that can be constant or intermittent. The epidemiology of tinnitus is about 10 to 25% of the general population is affected. The prevalence increases with age. 12% of our patients are older than 60, and 5% are aged 20 to 30. The pathogenesis is not well understood. We believe there's some activity in the nervous system without any corresponding mechanical or vibratory activity within the cochlea. There are multiple causes that include vestibular schwannomas, somatic sounds, osteosclerosis, presbycusis, toxins, noise trauma, barotrauma, eustachian tube dysfunction, acoustic neuromas, vascular abnormalities, and neuromuscular conditions can all be potential causes for tinnitus. So clinically, how do people present? It really varies in symptoms and levels of debilitation depending on the type and the level of sounds. Okay, and an important thing is to ask your patient to describe the sound, past ear history, sound exposure, and hearing status, as well as all meds, okay, to make sure you're not missing an ototoxic med. High-pitched sound usually implies sensorineural loss. Low-pitched sounds are usually idiopathic or Meniere's. Pulsing, rushing could imply vascular cause. Ocean-like sound is very often a eustachian tube dysfunction. And then clicking sound is somatic or TMJ or spasms of the ear structures. And this, your patient really might need to see a neurologist and have a full neurological exam. Ask about insomnia or depression. Those also should be included. So physical exam, complete ear, nose, throat, neck, and TMJ evaluation, okay, examination. So bilateral vascular assessment of the preauricular, temples, orbits, mastoids, and jugular veins are necessary. You need to do those. Hearing tests should be included, and a neurological exam. Diagnostics, there are a couple of really useful tinnitus questionnaires that help guide to causation. Definitely an audiologic eval could be needed and is appropriate, I think. They may need to see an otolaryngologist or a neurologist for evaluation. And then per your clinical impression and the history, please do not forget that one of our differentials should be Lyme disease testing. We can also look at a CVC with DIF for infectious causation or other issues. We need an ESR looking at inflammatory markers, those SED rates, and glucose and a TSH. All those are appropriate when working up tinnitus. MRI or a CT if you suspect CNS lesion. Management, unilateral is not usually serious. Bilateral, you got to question if you're dealing with a vestibular schwannoma, so the patient really might need MRI or CT, so make sure you discriminate unilateral versus bilateral. Pulsatile is always a referral. It could be a vascular causation, and just remember that. But you are going to assess those vascular structures. Eliminate ototoxic meds or toxic noise exposure. And TMJ treatment might be warranted if it indeed is part of this issue. And then anyone with severe tinnitus, please refer. You will find that people that have this benign condition can become depressed from it. So education needs to be related to causes, and of course, if any of the causes can be treated or eliminated, options for treatment can be reviewed, but they're not great. Reassurance that it is benign, and then well, there are a lot of resources available. There's support groups online, and there are those tinnitus questionnaires, and you can see a lot of different over-the-counter products claiming to eliminate tinnitus, but very often the patient just has to become acclimated to it. Thank you.